enormously, continuously.
An inguinal hernia is a defect or weakness in the abdominal wall that allows the passage of abdominal contents through the lower abdominal wall into the inguinal region or groin. Inguinal hernias are dangerous because they tend to keep getting larger and your intestine gets trapped inside the bulge and lose its blood supply. Inguinal hernias may occur on the both sides of the body and are much more common in men than women. Age younger than 5 years or older than 75 years, family history of inguinal hernia in first-degree relatives, impaired collagen metabolism, and previous history of benign prostatic hyperplasia or prostatectomy. Hernia can also develop over time if you increase pressure on the walls of your abdominal muscles throughout activities like straining to go to the bathroom, coughing over a long period, being overweight, or lifting heavy weights. If you have a family history of inguinal hernia, you may be at higher risk for one. Infants born before their due date are also at higher risk. Inguinal hernias can be classified by etiology, meaning they can be either congenital or acquired. Congenital inguinal hernias occurs when the processus vaginalis fails to close during gestation. On the other hand, acquired hernias can be due to patent processus vaginalis or a weakness in the abdominal wall, allowing intra-abdominal contents to protrude through the defect. Common causes of tissue weakness include abdominal wall injury or connective tissue abnormalities. Inguinal hernias can also be classified anatomically as either direct or indirect. A direct inguinal hernia protrudes medially to the inferior epigastric vessels within Hasselbalch's triangle, which is formed inferiorly by inguinal ligament, laterally by the inferior epigastric vessels, and medially by the rectus abdominal muscle. Direct hernias are usually a result of weakened inguinal canal floor. On the other hand, indirect inguinal hernias occur in the internal inguinal ring lateral to the inferior epigastric vessels. In the males, this is the site where the spermatic cord exits, while in females, it's the site where the round ligament exits the abdomen. This is because the male testicle starts inside the abdomen and has to go down through the opening in the groin area to reach the scrotum, the sac that holds the testicles. If this opening does not close at birth, a hernia develops. In women, this type of hernia can occur if reproductive organs or the small intestine slides into the groin area because of weakness in the abdominal muscles. Indirect inguinal hernias are the most common type of hernia, and they occur more frequently on the right side. Both direct and indirect hernias can present as either asymptomatic, symptomatic, incarcerated, or strangulated. In diagnosis, the first step is to obtain a focused history and physical examination. The patient should be examined both supine and standing, and also with coughing and straining, since small hernias may be difficult to demonstrate. The external ring can be identified by invaginating the scrotum and palpating with the index finger just above and lateral to the pubic tubercle. If the external ring is very small, the examiner's finger may not enter the inguinal canal, and it may be difficult to be sure that a pulsation felt on coughing is truly a hernia. So first you might identify a patient with an asymptomatic inguinal hernias. In this case, your patient does not currently have symptoms. However, on physical examination, you will notice a small, easily reducible bulge in the groin area superior to the inguinal ligament. The bulge may also protrude when you ask your patient to perform a Valsalva maneuver. Those maneuvers will reveal an abdominal bulge and allow the clinician to determine whether the hernia is reducible or not. The Valsalva maneuver is done by trying to breathe out forcefully with a closed mouth and nose, similar to the effort you would make when blowing up a balloon. If you see this, you can diagnose an asymptomatic inguinal hernia. Treatment of asymptomatic inguinal hernias can often be managed with watchful waiting principle, meaning that it can be left alone till it's growing or causing symptoms. However, hernias don't go away of their own accord. Over time, hernias tend to get bigger as the abdominal wall gets weaker and more tissue bulges through. In the past, there was the practice of wearing a special device called a truss, or support, to prevent the lump from coming out of the hole. However, it is now believed to provide little or no benefit and can be quite uncomfortable. However, you should advise your patient to seek medical attention if they have new onset of worsening growing pain or if they are suddenly unable to reduce the hernia. Okay, let's talk about symptomatic hernias. A patient with a symptomatic inguinal hernia may have a history of pressure or sharp pain in the groin, as well as heaviness after activity or at the end of the day. Some patients may also report pain or altered sensation over the scrotum or inner thigh due to compression of the ilioinguinal nerve. On physical examination, you might see a bulge in the groin area superior to the inguinal ligament, especially when the patient does a Valsalva maneuver. Just like with asymptomatic patients, this bulge is easily reducible. In this case, you can diagnose the patient with symptomatic inguinal hernia. Now, if your patient's hernia is symptomatic, they should be scheduled for an elective surgical repair, so be sure to call the surgical team for a consultation. In the meantime, you should counsel your patients to seek immediate medical attention if their pain worsens or if they are suddenly unable to reduce their hernia contents. Alright, let's move on to the patients who present with signs and symptoms of an incarcerated inguinal hernia. In this case, history might reveal pressure and constant sharp pain in the groin area. The pain might radiate to the scrotum or inner thigh. Your patient may also report changes in bowel and bladder habits like constipation or difficulty urinating. On their physical examination, you will typically see a bulge that is superior to the inguinal ligament. Now, unlike asymptomatic or symptomatic inguinal hernias, it will not be easily reducible. Once you diagnose an incarcerated inguinal hernia, you should assess the onset of the patient's signs and symptoms because this will determine the management. In the case of acutely incarcerated inguinal hernia, the patient will usually require urgent surgical repair, so call the surgical team for consultation. On the flip side, if the hernia is chronically incarcerated, you might attempt to reduce the hernia first. Before you perform a manual reduction of incarcerated inguinal hernia, you should administer pain medications and possible sedation prior to the procedure. Have the patient lie down and place them into the Trendelenburg position. Apply gentle pressure to the hernia while manipulating the content back into the abdominal cavity. After attempting to reduce the hernia, you should call the surgical team for possible hernia repair. Now let's talk about a serious condition called a strangulated inguinal hernia. In this case, the blood supply to the herniated bowel becomes obstructed, leading to the ischemia. Patients with strangulated inguinal hernias typically have a history of fever, severe sharp pain in the groin, difficulty passing urine, and possible sign of bowel obstruction such as abdominal pain, nausea, vomiting, and absent bowel movements and flatus. As always, the physical examination might show a bulge in the groin superior to the inguinal ligament. Additionally, the skin may be erythematous, warm, and very tender to palpation. In this case, you are dealing with a strangulated inguinal hernia, and you should not attempt to reduce the content back into the abdominal cavity, since the hernia sac may contain a necrotic bowel. Once you have diagnosed a strangulated inguinal hernia, you should start the patient on intravenous fluids as well as broad-spectrum intravenous antibiotics and place another gastric tube if the patient is vomiting due to bowel obstruction. Once those measures are started, call the surgical team for an emergent repair of the strangulated inguinal hernia. Also, differentiation between direct and indirect inguinal hernia on examination is difficult and is of little importance since most groin hernias should be repaired regardless of type. Nevertheless, each type of inguinal hernia has specific features more common to it. A hernia that descended into the scrotum is almost certainly indirect. On inspection with the patient erect and straining, a direct hernia more commonly appears as symmetric, circular swelling at the external ring. The swelling disappears then the patient lies down. An indirect hernia appears as an elliptic swelling that may not reduce easily. On palpation, the posterior wall of the inguinal canal is firm and resistant in the indirect hernia, but relaxed and absent in direct hernia. If the patient is asked to cough or strain while the examining finger is directed laterally and upward into the inguinal canal, a direct hernia protrudes against the slide of the finger, whereas an indirect hernia is felt at the tip of the finger. Compression of the internal ring then the patient strains may also help to differentiate between indirect and direct hernias. A direct hernia bulges forward throughout Hasselbalch triangle, but the opposite hand can maintain reduction of an indirect hernia at the internal ring. Those distinctions are obscured as the hernia enlarge and distort the anatomic relationship of the inguinal rings and canal. In most patients, the type of inguinal hernia cannot be established accurately before surgery. In the operation room, surgeons may perform two main types of surgery. First is open repair. The incision is made throughout the skin in the groin area. Next, the surgeon moves the hernia back inside the abdomen and closes the abdominal wall with stitches. Mesh placement may be used to straighten the closure and reduce the risk of recurrence of the hernia. Laparoscopy or robotic assisted repair, this type of surgery uses a few small incisions and a thin scope with a tiny camera. The surgeons work throughout the scope to repair the hernia, sometimes operating from a console maneuvering robotic arms, and mesh is typically used for those repairs. Recovery is shorter and pain is less severe after those minimally invasive approaches than with open repair. Also, don't forget to consider other possible causes of groin pain than making a diagnosis. Groin pain, which can originate from musculoskeletal issues or be of uncertain origin, often becomes noticeable during strenuous physical activities, commonly referred to as sports hernia. And it can be challenging to distinguish this from an acute hernia, even after a thorough physical examination. In such cases, an MRI can be useful in identifying the root of the problem, such as inflammation, edema, or muscle or tendon tears or strains. There are instances where herniation of preperitoneal fat into the spermatic cord, known as lipoma of the cord, is mistakenly identified as hernia sac. The true nature of this condition may only become clear during surgery. Occasionally, a femoral hernia that has extended above the inguinal ligament after passing through the fossa ovalis femoris may be confused with an inguinal hernia. If the examining finger is placed on the pubic tubercle, the neck of the sac of femoral hernia lies lateral and below, while that of inguinal hernia lies above. Inguinal hernia must be differentiated from hydrocele of the spermatic cord, lymphadenopathy or abscesses of the groin, varicocele, and residual hematoma following trauma, or spontaneous hemorrhage in patients taking anticoagulants. Additionally, then a testis cannot be felt into the scrotum. The possibility of an undescending testis within the inguinal canal should also be considered.